Hello, my name is Dr. John Campbell. I'm an emergency room physician and a family practitioner whose practice involves obstetrical deliveries. And what I'll be speaking on for the next 20 minutes is maternal resuscitation. As you take a moment to read the specific objectives for the next 20 minutes, I'd like to bring a couple of things to your attention. The first thing is that the algorithms that you've learned for basic life support, advanced cardiac life support, and advanced trauma life support all apply to the maternal patient. Where we're going to talk about some of the differences are in the predictable changes in the anatomy and physiology that occur during pregnancy that can affect what it is that you'll have to do as a provider. The thing that you need to remember is the resuscitation of a maternal patient can be particularly stressful because as a provider you're caring for both the mother and the unborn fetus. The most important thing to remember here is that by treating the mother, you're managing the fetus. There's another thing that's particularly important for us to remember, and we're going to discuss it in a little bit more detail, is that there's a significant amount of changes in the hemodynamics of the pregnant patient that affect what it is that you're going to be required to do as a provider. The physiology of pregnancy changes what it is that we're going to be required to do. Pregnancy is a hypervolemic state. The mother has more blood in her circulation than the non-pregnant patient, and it's important to remember a couple of things about this. The first is that the uterus is going to receive nearly 20 to 30% of the cardiac output as the patient gets near term. This has some significant implications in the management and recognition of hemodynamic problems in a pregnant patient. The other thing that we need to be cognizant of is that the gravida uterus in the supine patient actually pushes down on the inferior vena cava and makes it possible to sequester 20 to 30% of the venous return in the legs. That leads to a relative hypovolemic state in the pregnant patient. As a result of that and normal physiological changes that happen with blood pressure and heart rate, the signs of hypovolemia can actually be masked in the pregnant patient until there's a rather significant blood loss of about 1,500 mils or 1.5 liters of blood. The other things that we need to remember with regards to the physiology of pregnancy as well is that the hormones released by the body to cause the uterus to relax also slow the progress of food through the digestive system. As a result, there's a delay in gastric emptying. This has got some implications with regards to endotracheal intubation, where the provider would be well advised to consider the use of cricothyroid pressure when passing an endotracheal tube. In addition, it's important for us to consider orogastric tubes for stomach decompression in trauma patients early on. When you do the blood work on the maternal patient, you're going to find that there's a few subtle changes as well. The first thing is you'll actually find that the BUN and creatinine will actually be lower in pregnancy due to an enhanced glomerular filtration rate. Another thing that's particularly important on the arterial blood gas that you may do in a maternal resuscitation is that the oxygenation parameters change quite a bit. Within pregnancy, the O2 consumption is markedly increased, and as a result, the PaCO2 of 35 to 40 millimeters of mercury may actually indicate respiratory failure in the pregnant patient. As we said in the beginning of this presentation, the primary survey that you're going to use is going to follow the algorithms that you're already familiar with from your other life support courses. We're going to begin with the airway assessment, and where necessary, open the airway, suction the airway, and consider placement of an oral airway. The next thing that you'll do is you'll assess the breathing, and if required, support it with positive pressure ventilation using a bag valve mask device. With regards to circulation, if the individual is hemodynamically compromised in such a way that they don't actually have meaningful cardiac output, you begin the chest compressions. You'll also attach your monitors and consider the possibility or requirement for defibrillation, specifically looking for ventricular fibrillation or pulseless ventricular tachycardia. If everything that you've done in the primary survey has been successful, or in the best case scenario, the interventions in the primary survey have been unnecessary, you'll then move on to the secondary assessment. The secondary assessment in a trauma patient may involve the placement of an advanced airway, or after the resuscitation of a cardiac patient where you've got return of spontaneous circulation but without return of normal baseline neurological functioning, you'll place in an advanced airway. The next thing that you'll need to do is you'll need to secure that tube and confirm that the tube is appropriately placed. At this time, in the non-pregnant patient, you'd use a chest x-ray to confirm the appropriate placement of the endotracheal tube, And that is still the appropriate thing to do in the pregnant patient. There is a risk associated with the administration of X-ray energy to the unborn fetus, but that's secondary in considerations to ensuring that the endotracheal tube is placed properly. Circulation, if you haven't already done so, it'll be necessary to secure IV access. You'll put the patient on a monitor, make sure that you've got the appropriate rhythms, and administer any of the life support medications that you would possibly use in a non-pregnant advanced cardiac life support scenario. You'll also then move on to the D, which is to consider the differential diagnosis, which is to look at the reversible causes that may have put your patient in the extremis in which you find them. What's different with regards to the maternal patient is the requirement to carry on with the fetal survey. There's a number of things that we actually look at. One of the first things that we look at is the fundal height. That's particularly important because it'll give the practitioner an indication of how far along the pregnancy is, and that's got some implications that we'll be discussing a little bit later on. The fundal height is also important as well because an early pregnancy is protected by the bones of the pelvis. Midway through the pregnancy, the abdominal wall, the myometrium, and the amniotic fluid will actually protect the unborn fetus. Later on in the pregnancy, when the bulk of the fetus is in a uterus that's higher up in the abdomen, that changes the implications as a result of whatever trauma might have been applied to the person's body. Fetal presentation is particularly important as well. They'll give you the indications of possible uterine rupture, and later on, as the pregnancy progresses, the fetal head moves back down into the pelvis. Fractures to the mom's pelvis, in this case, equal fractures to the child's head. Uterine activities are particularly important, and we're going to talk about that a little bit later on in this presentation with regards to trauma to the uterus. Fetal heart rate and pattern is particularly important. The most sensitive indication of what's happening with the mother is what's actually happening with the baby as expressed by the baby's fetal heart rate. A fetal heart rate of between 120 and 160 with good short-term and good long-term variability is actually very reassuring. The opposite is also true. It's also important to pay attention to vaginal bleeding. The myometrium is actually very flexible. The placenta is inflexible. Where they interface together, the placenta becomes particularly susceptible to the shear forces associated with traumas, and as the placenta moves away from the myometrium, you get an abruption, and that's got some pretty potential catastrophic implications for the fetus. It's important to pay attention to the membrane status. If the membranes are intact or the membranes are ruptured, that's going to change some of the things that you're going to do. And it's also important to pay attention to what's happening with the cervix. This is a graphic drawn from the ALSO course that shows the positioning in a maternal cardiac arrest. One of the things that's important for us to do is actually get the patient into the left lateral decubitus position. You remember from when we said earlier on that the gravida uterus can impact upon or compress the inferior vena cava and decrease cardiac return. It's important to move the person into about a 30 degree of left tilt in order to effectively do chest compressions. If this is actually being done on a stretcher in the emergency department, it may be necessary to put two stretchers together and lock them so that one of the individuals can get up and use their knees as a base. If you don't have the two stretchers, it's entirely acceptable for one of the individuals to apply force to the uterus and displace it off of the inferior vena cava by pushing it from right to left. Chest compressions and bag valve mask compressions or airway management is the same as for any other ACLS scenario. One of the things that we need to be cognizant of is perhaps the requirement for a perimortem C-section. This is a very uncommon occurrence, but it's important for you as a provider to be familiar with it. There's a few things that you need to be aware of. The first thing is that the fetus of an apneic or asystolic mother actually has less than about 2 minutes of oxygen reserve. As a result, if we're unable to restore satisfactory maternal circulation within 4 minutes, you need to consider the perimortem C-section. Before you go ahead and do something like a perimortem C-section, you need to be aware of the requirement or some of the requirements for this procedure to take place successfully. The first is that the fetus needs to be about 24 weeks in their gestational age, and you need to have adequate resources to undertake the appropriate postoperative care. If it's necessary to perform a perimortem C-section, one of the things that you need to be cognizant of is you need to wear all of your personal protective equipment. That's part of the universal precautions, and you should actually have it on anyways prior to doing a traumatic resuscitation. But it's worth mentioning that you need to make sure you have your gown, your gloves, your mask, and your eye protection. You'll do a vertical midline abdominal excision. You'll do a vertical uterine incision. You'll remove the infant and the placenta. The infant will be placed in warm blankets, and if you've got it, an infant warmer, hand it off to another member of the team. Then it's going to be necessary for you to pack the uterus. If you think about what we talked about at the beginning, the uterus gets about 30% of the cardiac output. If you remove the baby from the uterus and you pack the uterus, that 30% of cardiac output is now available for the mother. And that's why the perimortem C-section can be potentially life-saving. You repair the anatomy when the patient is actually successfully resuscitated and stable. Now, from something that's less likely to be seen and something that's more common in our practice with regards to maternal patients, we're going to talk about the trauma that can occur to the uterus of a pregnant woman, either as a result of slips or falls, or more commonly, automobile accidents. It's important for us to realize that because of the discomfort and fear and ignorance around the use of seatbelts during pregnancy, that seatbelt use declines in pregnancy. That's unfortunate because it can reduce the serious incidences of death and injury by about 50%. The proper position for the seatbelt is to actually have the shoulder belt between the breasts and the actual lap belt below the gravida uterus. There's also no indications to suggest that airbags do anything other than help mothers and babies. Motor vehicle accidents are a frequent presenting complaint for uterine trauma in the maternal patient, as well as other things like slips and falls in the bath or falls downstairs. So it's important for us to spend a little bit of time talking about the required monitoring of the maternal patient who sustained some form of trauma, be it mild, moderate, or severe, to the uterus. The first thing that we're going to do is we're going to put the individuals, if they're greater than 20 weeks, on a monitor to monitor for uterine activity. If they've got less than 3 uterine contractions per hour over a 4-hour period, then it's safe to discharge them from your institution with advice to return should there be any changes in the condition. If you find that the number of uterine contractions is between 4 to 7 per hour, then the individuals actually need to be observed for 24 hours. The discharge criteria from your facility is that there's a resolution of contractions, there's a reassuring fetal heart status, the membranes are intact, there's no uterine tenderness or vaginal bleeding. In summary, the resuscitation of the mother always takes priority over the resuscitation of the fetus. By treating the mother, you're managing the fetus. When we do our resuscitations, we employ all of the same algorithms, drugs, and techniques that you've learned in your basic life support, advanced cardiac life support, and advanced trauma life support courses. It's particularly important for us to be cognizant of the need for the left lateral tilt to improve the venous return of the maternal patient during a resuscitation. And although rare and infrequent, a perimortem C-section may be life-saving for the mother as it allows for an improvement of the circulating blood volume. Thank you very much for your attention, and I look forward to working with you in the skills session of this course.